UHC conversation continues with Dr. Abdi Mohamed, who is the chairman of the Kenya Association of Private Hospitals, and Geoffrey Mwangi, who is a former NHIF CEO and expert on health financing. City, remind us the day's proverb.
Makali ya jicho yashinda wembe.
Makali ya jicho yashinda wembe. Okay, we already got the translations. So we move straight into the conversation back, right?
Definitely.
Sawa. So there are 4 funds now that have been established.
3.
Yes. There?
Yes.
Primary Health Fund.
Primary.
Social Health Insurance Fund.
And the
Critical Care Fund. I'm adding the 4th one there. Facility Improvement Fund on the side.
Okay. That is an aspirational fund.
Well, it's because this is money that's being retained. That's why you're not calling it a fund. Who is going to manage these 3 funds? Is it the 3 different entities or is it one entity?
One entity, one board, one management. And actually it is it's meant to help each other, build on each other. So you will have the primary health care, which will do the promotive, preventive, so that it also keeps for the tier 2, which is the social health, so that you have as minimal as possible coming into this social health.
Yeah.
Then the final bit, the third one is the critical illness and emergency. So the critical illness is more of, I would call excess loss in insurance terms. So what happens is you have a benefit, then you exhaust, but the disease is still in place. For example, cancer. So you are not let go and said your 2 sessions are over, your money is over, and then now go home. So instead now the critical comes in and says, okay, let's continue treating you until such a time you are well. So that's the whole essence. But the critical is with the emergency fund. So emergency is for any emergency that you come across.
Okay. We would also like to know how these 3 funds essentially are funded. So the primary health care, one is to assume that is coming from the money that's deducted from you on a monthly basis, whatever, right? The 2.7%.
No.
This is budgetary allocation.
No. Okay, so this money comes from Treasury.
Yes.
Now, social health is what takes in your
it's where
your contribution.
Your contribution goes to. Now, critical health, critical illness and emergency, then where does this money come from?
It's also tax funded.
It's also tax funded, but not fully tax funded, from what we're meant to understand.
It's fully tax funded, but it also could come from different sources, like let's say tobacco fund.
Yes,
there's a certain part of it that usually they collect, so it could be used as part of the critical illness fund.
So 2 things.
So basically, I would say tax funded. It doesn't come from you directly.
Absolutely.
Yes.
So 2 things we were told that possibility, syntax, like you're talking about now, that would go there. But then we're also talking about some donor funding that would then go towards this critical illness fund.
Possible,
right?
yes.
Possibly. All right. So what is happening at this primary health is that you're guaranteed to get that first level of care that you would essentially find at your level 1s, your 2s, your dispensaries and all of this, right?
Yes.
And this comes from Treasury, fully funded across board.
Yes.
Now, what also we're trying to avoid by this, I can see directly, is that everybody then who was flocking to your level 6s to then get a stitch or to then get, diagnosis for flu or something, or broken arm.
Or diarrhea treatment.
Exactly. So essentially what we are seeing is that all of that will be cut out. Now, one of the things that we saw, oftentimes would be complaining about, is that there's huge bills when it comes to power in certain parts, running water, essentially the equipment for facilitation that is required at this level. Will we then be able to guarantee that all of these things are taken care of, so that in the event that you do present yourself at any level, that you would be taken care of? Because usually the reasons why people would move this step is because these facilities were not equipped. Is it not?
Yes.
Okay. So how would that then be guaranteed to be taken care of?
You have three options at that level, of level 2 and 3. A public facility, a mission facility, or a private facility. So if you go to a mission facility and you feel they are not up to the task, you can go and walk to a public facility. If you go to a public facility and you feel they are not up to the standards, you will move to a private facility. So the options, the chance of all three failing are very minimal, in my opinion. Unless something catastrophic happens, that in a primary healthcare network, that all three facilities are at zero, will be and whatever that they can't provide, they are allowed now to refer you to a level 4, a level 5, and a level 6.
So should it not be aspirational, whereby the insistence should be that at this level, it doesn't matter whether it's public, it doesn't matter whether it's private, that these institutions should actually be equipped fully. It shouldn't be that I'm going to go here and because there's no syringes or whatever, let me find my way to a private facility because the card is available for me. Should it not be that we're making sure that across board, it doesn't matter whether it is public, whether it is private, whether it's church-based, whatever, or, faith-based, it doesn't matter, that everything, and that I guess is the due diligence that we're making sure is available across board everywhere in the country.
And that's why if you look at the Act, it talks about a different authority to do the quality and assessment of those facilities and the empaneling to say city's facility is fit for purpose and can provide this service. Contract them to provide this service. So when that authority comes and says, in this area there's no facility that can provide service, now that's where you will have the issue of how do we...
This fourth bill that Eric is looking for.
The one where, the one for tender
let's
of building structures with no...
let's build structures
with no products.
And let us establish a health facility with everything that's needed.
And that's why you have that quality authority that will do that work.
You know what I find strange though? Huh?
Yes.
We have public-private partnerships in every sphere.
Yes.
What would a public-private partnership look like in the healthcare service?
I think the provision of equipment. We had like the MES. I think that was a private-public partnership.
How did that one work out?
Counties that have never had those things will tell you the price or the method that it was done was wrong. But in terms of service to the people, you see, there are two things. There is the process that it was done, or the cost is one thing. But in terms of providing services, for the first time we had almost every county had a dialysis center, and that was part of the equipment mess for the first time. And there was a payment mechanism that was also addressed.
Most of them, they had pegged them from the reimbursement we were giving them to cater for dialysis, to cater for chemotherapy.
So you don't need to come from Mandera to KNH for dialysis. You would get them in your own county. Before that, everyone was either moving to the big cities, because even the ones in the private sector were not affordable. And there were only very few facilities that had even the private sector, the big hospitals. So you would say almost maybe 10 were only available, and they were only available in cities. Smaller counties, 0. Not even one dialysis machine. And that's the difference.
And now what we are saying is that will happen, right?
Now what's going to happen is this act is going to now cater for the financing mechanism. So now the service delivery is now being done by public-private mission. So where there are gaps, definitely there will be someone who will fill in. Whether it will be filled in by the mission, or it will be filled in by the county, or it will be filled in, because if there is demand, definitely someone will supply.
Oh, okay. All right.
You're really happy
before you
with
go
this.
there,
Yes.
before we come back, I just want to come back and ask you a question. This amorphous being that's going to do these things, do they also constitute this quality assurance and control team? Who are these people? Who is this team?
No,
where do they come from?
No, there will be a quality authority that will make sure that it panels and it looks at the facilities
From
in terms
where?
of it's a national body.
Okay.
An authority is going to be created
Yes.
Okay.
from these laws
Yes.
that does this.
Yes.
Okay.
Yes.
I think currently is a KMPDU, which
KMPDC.
is
The
union.
No, not
the
the
union.
KMPDC. So you will have an authority that will look at the quality and the standards of those facilities. That will make sure that these they are the ones who will empanel those facilities and look at and say, facility X meets the standards, facility Y does not meet the standards, so close it. Facility Z meets the standards. And the FIF now comes in to help public facilities maintain and retain their money so that they can continue providing the services, so that they don't run out of commodities, they don't run out of all other things that they need.
What safeguards do we have
Yes.
to make sure that even private facilities and faith-based facilities that receive money from this social insurance scheme are not misappropriating their money?
It's in their interest to continue providing services.
And
They
that's-
don't have budgetary allocation.
It could be in their
And
interest.
that's
to
what I was
steal money.
saying. Link fencing should not only be towards government facilities.
Yeah.
Link fencing of health funds we should have mechanism of how do we, even from the private facilities, that whatever comes in as health money does not go out to do other projects.
Yes.
How would
Whatever
that be
SHIF
contained to
pays to your facility, you are not using it to say, okay, now we have an expansion program, and that expansion program is basically the director's scheme of siphoning the money out of this thing.
I will give you an example. You own a company for transport,
Yes.
and you are contracted by government to deliver goods from Mombasa to Nairobi,
Yes.
and then they pay you.
Yes.
You decide to eat the whole full amount. Then they tell you there is another cargo in Mombasa we need you to bring. Where will you get the fuel to bring and pay the driver? In the public sector, that did not matter. You would say, we don't need to provide that service. Let the facilities remain as they are, or we are waiting for budgetary allocation. But in the private sector, it's in your interest to fuel your car, pay your driver, so that you go back and collect that goods and you are paid again. So for me, I don't see any problem when it comes to mission and private, because it's not about, you see, your whole essence of existence is to sustain sustainability. You don't have budgetary allocation coming from elsewhere, and you are not dependent on anyone else. You are dependent on the services that you offer is what is making you sustainable and continue operating.
You know,
And the way these three bills work is money follows services. You provide service,
that's all very true.
I pay
In
you.
an ideal situation, and I think that's what Geoffrey also argued, in an ideal situation, somebody will look at that and say this, but corporate governance kicks in. In the public sector, there are layers of accountability in corporate governance. There will be an auditor who will come and audit your funds, and they'll raise the flags, and Parliament will ask questions, and there'll be people who will be fired to make sure that we maintain Kenyatta National Hospital as a going entity, right? In the private sector, if City Hospital brings in directors, and the management and directors are basically stealing from this facility, this facility will collapse. And it will affect that whole network that we are talking about. The point is, City Hospital will no longer exist, and there will be no questions that we can ask. Remember, the social health insurance contributions have been funding this facility. CT and his directors have taken money from the facility and gone and done whatever they want to do. They have bought trucks because they want to enter into transport business and move away from this.
And
Yeah,
even,
talk
now,
about
and,
it.
and even now we have some facilities which have problems.
All these issues.
That Dari can talk about it.
Yes.
But the key things, the key impediment which comes in is that now the insurer, when it comes to what we call payment mechanism, is a bit choosy on if I'm to deal with a private entity. What payment mechanism do I apply? There are those which are more progressive, the others which are retrogressive. But you find you cannot apply the progressive ones to a private entity because you do not know where the funds will go. Yep. Like capitation, for example, if you give them money upfront, they will use that money to do other things other than promote health.
Yeah.
But for a government entity, you know the money should be meant for that purpose and should go back to the same purpose.
And now with the law, that money has been ring-fenced. So even if you give them capitation money in advance,
yes,
you know this money will not leave. And if it left, the Auditor General will find that the money left.
So I want to correct one thing.
Correct us.
The social health insurance is not funding you. It's paying for service
That's true.
that you have delivered. Number one, that's one thing that you have to keep in mind. And the service you have delivered had inputs. You bought medicine, you bought reagents, you bought a machine, and you hired a doctor to pay. So when you are paid, you are distributing the money that you have been given. So let's remove the misconception that you are being funded. You are providing services that you are paid for. So it's in your interest as a provider that you are able again to buy the medicine, the machine, and the equipment, and hire the doctor.
The companies
So what
that
happens?
go under,
Yeah, I'm coming to that.
And we have very many cases in the retail space everywhere. Those companies go under because there was poor corporate governance. They go under. In our particular case for health, the cost is higher for the public because when this one particular facility gets off the network is now imbalanced. There's a bigger social cost if a health facility misuses or mismanages its funds. That's what I'm saying.
Or even fails to retain quality.
Or fails to retain quality.
Yeah.
And that's where I was coming to my next point. You see, when CT's facility collapses, it is it's because or in Embakasi and Ngong, in all the areas that have problems.
Not only that, I also went and built a hospital in that very line.
So that doesn't mean that, first of all, as we speak, it's not that hospital building or construction of new facilities are going to stop. As demand continues, there will be new ones that will be coming in.
Yes.
So if you have one getting out of way, you will have Eric Latif moving in and taking over that same space. So for me, I don't see any challenge in terms of whether the directors misuse or not misuse. What matters at the end of the day is this facility providing the services that's required to the quality that's required? That's the most important thing. The moment they can't, then they are removed from the network and you have a new facility that will come into that space.
Jeff, this new law also talks about the new entity, the Social Health Insurance Fund, as it's going to be called, and sort of raises questions about its capacity to handle the job that it's being given to do. From how you understand NHIF, having worked there for many years, having led it, is it able to manage all these funds and to manage UHC? Or does it need, external support here, external support there? Does it need to bring in, for example, another entity to help it in recruiting, another entity to help it? And I'm asking that specifically because it opens a window for the NHIF, the new NHIF, to bring in another entity, a private sector entity, to help it with claims. and processing of those claims. Is NHIF incapable of doing that?
Being a parastatal in a government body, it's capable of doing that. And I want to believe even the new body being formed, that is the Social Health Authority, should be capable of doing that. But that doesn't mean that some aspects cannot be outsourced. So the issue is basically what is to be outsourced. But it should be the body to have the bulk of the processes. In NHIF, like we outsource the provision of underwriting of group life and last expense for some category of people to other payers in the industry. That doesn't mean that we didn't have the category, the capacity, but maybe our setup could not allow us to undertake that very aspect. So outsourcing is allowed, but the issue is exactly what it is that you are to outsource.
Now, this particular
and you cannot
case,
outsource your core. You know, your
in
core.
this particular case, they are required to outsource processing of claims.
Well, maybe I wouldn't know about that, but what I would suggest is that your core, you should retain your core. But the other areas you can outsource, like maybe you have some cohorts accessing outpatient services, you can outsource to one payer provider along the stream and handle that, depending on their circumstances.
What is the core? What are the core services that this social health authority should provide?
For any social health authority, the core comes in as your member base. You should be the one to have your membership base. You should be the one to call out on the benefits packages you're driving, and engagement with the providers of the same services. That is,
engagement is contracting them.
Contracting can be done elsewhere, but when they are on the panel, that they are providers, that you should engage in them in terms of their claims and the services they are offering, because that's where you come in now to pay them. So those are the three parameters.
Would there be a negative?
Of any social.
Would there be a negative if claims are handled by an external entity? Like if the authority subcontracted another entity to handle this, you know, we're receiving very many claims on a daily basis from all the facilities across the country. Maybe somebody else handles that. You break
entirely.
Away. Yes.
But which other authority would be bigger than the one? Who is the other bigger person than the authority? Maybe I don't know.
No. I understand where the question is coming from, and I know the genesis because there are providers who are jittery when it comes to this issue of outsourcing. So when you look at the Act, the way it has been designed, it moves away from what NHIF was. So NHIF was doing certain things, literally A to Z. So they were the ones who were recruiting members, collecting the money, designing the benefit package, empaneling facilities, contracting facilities, pre-authorizing, claim processing, payment, resolving disputes.
Everything.
Yes. One person. I, the one who decides how you move and what you do and what you say. So this new authority tries to relinquish some of those things so that there are checks and balances. The tendency is when you have that concentrated power in one individual is where now issues come in, underhand deals, kickbacks and all those things, because I'm the one who decides whether to approve. Yes. I'm the one who decides whether to give you the contract or not to give you. I'm the one who decides whether to approve.
To pre-authorize.
I'm the one who decides whether to pay your claim or not to pay. I'm the one who decides if you have a problem to tell you go to hell and close your facility. So what this new authority has done is empaneling has been outsourced to the quality authority. So the first initial, who decides this person can do this work, it's somebody else. So that at least you are not the one who is concerned with all these other issues of empaneling. Then the second thing, they will collect the benefits, the premiums. The Ministry of Health, I think that's what it says, will come up with the benefit packages of what are the things that needs to be, what is the thing that is your tariff that you will pay to the facilities, and what will you give as an entitlement to Eric to say, Eric, this is what you are entitled to
as a contributor.
As a contributor for your social health.
So that goes to the ministry.
To the ministry.
So ministry comes up with benefits and tariffs.
Tariffs.
Okay.
So then you have the next part where you have now pre-authorization of those benefits to the facilities. It's done by the social health insurance. And that's one thing that most providers are not aware because they haven't looked at the way the Act speaks. So it's the payer now who decides you raise pre-authorization, then I'm the one who approves and says, yes, proceed, Abdi, proceed with this procedure.
Okay.
So the biggest hullabaloo is why are we outsourcing the claims? As you have said, there is...
and the claim is separate from the pre-authorization?
Yes. Pre-authorization is done by the Social Health Authority. Claim processing, looking at this benefit. And you know, these are things that have already been predetermined. So the benefit is known, the amount is known, and all those are already in the system. And that's with the authority. To say you are entitled to cesarean section, it's 30,000, and that's what we are going to pay. So you will do the pre-authorization, they will approve, because they have looked at what you have raised the amount, whether Eric is really entitled to that benefit, and then they will say, tick, proceed, and do. Now what you have is the...
So the facility raises an invoice.
An invoice. Now is to look at... It's basically a clerical work to just check what was pre-authorized and what you have raised are correct. The details are also correct in terms of patient, the number, the amount. So basically, it's just to make sure that this thing actually makes sense. And then they say, yes, pay. This is clean claim. So now who pays? It's the Social Health Authority that says, okay, this has come in. We make payment. But they also do audit, cross-checks to just make sure that whatever Ndu is sending as one of the claim processor. So it's not only one body that will do the claim processing, in my opinion.
5.
It can be even 6, 7, 10.
There'll be up to 5 according to the law.
No, the law, that has been removed.
It has been removed.
It has been removed.
Okay, so it's not open.
It's to decide the zoning in terms of different areas because of the numbers that will come in. So if Ndu, suppose, approves claims that are fake, so Ndu, who is supposed to be, as the Act says, MIP, will be held liable. And they are regulated by the Insurance Regulatory Authority. So you, as the social health, you don't have to go to individual facilities when there's a problem.
That's Ndu's work.
That is Ndu's work that you will hold accountable and you will punish, either removing or even withholding, whatever it is.
Or jailing.
Yes. So it will be Ndu. That is where now the money has been approved, the claim process internally has been done, the reviewing, and it's good to go, the payment is proceeded. So when you have a dispute, like suppose you are not comfortable with certain things, or they come and tell you your facility is this, you have, or you have been raising fake claims. So now you have a new body, a tribunal, that does dispute resolution, which will be
between
appointed.
the social health, the facility,
or even individuals.
And MIP.
Even individuals.
Or individual contributor,
A
patient.
contributor, if you have a problem, that maybe the social health authority, the board and the management were unable to solve,
My problem.
or you are uncomfortable with their decision.
Okay.
If still the act says, if you are uncomfortable with that independent tribunal, you can appeal to the High Court.
Okay.
If you are uncomfortable again with their decision.
Let's take a break. We'll come back and look at that structure again, see whether it makes sense to separate all these roles, or is it going to lead to more efficiency in service delivery or not. 20 minutes to 10. Quickly tell us about the graduations that are taking place across the country. I see even Kabianga University.
Is graduating.
So is there a jam heading to Kabianga University?
Spice.
Eric is a contributor. He's being deducted 2.75% goes contributing to this thing. The money is going somewhere. Where is it going to?
It's going to the Social Health Authority.
Okay.
But you know, one other thing that I want also to clarify is we always look at this social health as the people who are employed. This social health is meant for everyone.
Yes.
Which is 80% of the contributors will be the informal sector.
Bas.
So the only people who will do this formal contribution will be around 15 to 20%.
Yes.
So the biggest headache the new body will have is how they collect.
How to recruit
And collect.
and collect from the others.
Now imagine if they were busy also trying
Jeff
to
will
approve
tell us what he
claims.
did, because he was collecting 500 bob. He was collecting 500 every month.
We may not have the advantage of having the whole process that will be, because the regulations are not yet out. But from his explanation and from I see, like what happens in South Korea. Like South Korea, they have an NHIF. And they have another body they call Health Benefits and Tariffs Body. The NHSIO does the work that our social body here will do. But this other body does the tariffs, does the verification, and also submits to the other body to pay. So that bit can be done of
So the one that
verification, because what he's saying, it's verification. That's different
of
from
bills.
That's different from outsourcing claims management. Because even as at times in NHIF we were reaching that decision of how would we have a panel of doctors relooking at some procedures that were done and to authenticate and confirm that ideally this was okay, this was correct. If this was the presentation and this was the treatment, this was fine, you can proceed and pay. That's different from outsourcing claims management. So
in this particular case, in our case, what we have is the Ministry of Health is the one that is doing the tariffs and setting that base and saying, for this kind of service, this is how much you pay. For this kind of service, this is how much you pay. And they set like a policy.
Because they should have the muscle of doing the costing of health services, which is very key component, which I think is a gap that we really missed. We had started doing it with the help of World Bank, but I think after I left, it collapsed at some point.
So
because that's very key to determine.
Does the ministry have that capacity?
Well, they have the muscle to even get experts on board
to build the capacity.
The process, yeah,
okay.
Exactly.
So once they've done that, then the new social health authority is collecting the money from all its members, all right, and it's managing this money. The new social health authority receives a request from a facility. It's also the one that's recruiting facilities.
No, the empaneling is done differently.
By a different...
we will make sure the quality is done properly. So they will contract.
And maybe whoever does the contracting should follow up to ensure that are these people still living to the standards that we set for them.
Okay.
Yes.
So once we start receiving, Eric goes to a facility.
Yes.
And the facility determines that this is Eric's diagnosis and this is the kind of treatment that Eric needs.
Yes.
The facility sends that request to the social health authority to say, can we go ahead and incur these costs
And proceed and do the procedure.
and proceed and do the procedure? So basically, what there is, the response that they receive is like an LPO,
Yes.
right?
Yes.
Their pre-authorization.
Yes.
You get an LPO as a facility.
Yes.
Go ahead and incur cost of up to this.
And that's where now you can also have technical people
That's the
to
question.
sit on this other end at the Social Health Authority.
It's important to have technical
Yes.
people.
Yeah.
who-
Unfortunately, NHIF did not have. What they had is more of not doctors per se. They had clinical officers and nurses who are doing those predeterminations. So with the Social Health Authority, what they need is to have now, even if it means not employing, but just outsourcing to even a panel of doctors and tell them, this is the request. Is it really the next line of treatment, or is this how it's supposed to be done? And do give a professional input and say, no, this can be done, or this should
This
be
will
done.
consume time.
That's why I'm telling you.
So what, because even this whole pre-authorization thing, it's time consuming,
No, there are
and
things
it's
which are-
questioning.
There are things which
The-
are very
the-
clear.
The pre-authorization only comes to confirm what we have set as the things we are gonna pay.
Okay.
Are you in line with them?
Not
Because
questioning-
you are not seeing the
questioning
patient
why
yourself.
should this procedure be
Yeah,
done.
you are not seeing the patient. You don't
Okay.
have the patient.
So
you
you're just
cannot
saying
question some things.
the facility is requesting that we do a procedure X, and procedure X will cost this much. So the pre-authorization is just checking, is this what we have agreed as the cost for procedure X? Is that
Exactly. And actually, what the people that Taria is saying, what their work was meant to do is to do what we call surveillance. To go and come
the
say hi to you
facilities.
in hospital. Why are you actually in hospital?
Yes.
Because how would you again know?
No.
And some bit, you need some metrics to do surveillance.
Yeah.
To know exactly.
So it's
the
a bit-
hospital is treating people. The hospital is actually even open.
Even the other
If you
health,
never visit-
even the other insurers have the same people.
Yeah, and I can tell you, like when you look in the other our private health insurance industry, I was looking at a report of this 2021. 20, yeah, it had 20 and a couple of years there. And the only year they made profit was a year when we had Corona, because people could not visit hospitals, people had fear. That year they made a bit of profit. But the other years you'd find they also operate in losses. And the big contributor to the losses is medical fraud. It is there, it is real. You have to be very actionable in how you deal with it and how you...
So then I guess the overriding question here is then what guarantees that this is not going to be just another platform for this medical fraud that we speak of?
the architecture and what goes into it.
It's
will
the way you
determine.
design.
And the key thing, and what
So long as you
should
have
deal
people-
with, what should deal with the medical fraud is you need to have progressive payment mechanism. How do you reimburse your health facilities? Like what NHIF has been doing all along is what we call rebate. Rebate capitation we brought in when we started outpatient services. Rebate it's outdated. The facilities have learned how you do your game. So if you don't change and keep, and this is where we were moving to, if you don't change it to a more progressive one, you'll be outdone.
This story of medical fraud always keeps coming up. But you see, for fraud to happen, you need all parties to participate. From the guy who is the insurer, the patient, and the hospital. All three must align to defraud, because there is no other way that can take place. For example, you as a patient...
The patient can be innocent.
No. Sometimes you will find the patient is the one who initiates.
It's initiating the fraud.
It is CT who has insurance, but CT has a son who is called Eric. Eric doesn't have insurance, and he brings Eric to be, or has a brother who is Eric. But because Eric does not have a card, he says, use my card. So for me to use your CTs, I have to accept.
As a facility.
You, as the patient, also know that you are using CT's card. It's not yours. So you are also part.
The problem
And
comes
passive.
when death happens.
And you are part and parcel of it.
Wow.
You understand?
That's where the problems.
And you know, for this one, what will save us, in my opinion, is because everyone is mandatory to be part of the scheme. So it doesn't need, you don't need to have his card. You will have your own card. So that way, one way that it will
You've balanced it
Most-
out.
So you're suggesting that everyone who is an adult in this country will be registered?
yes.
That's the law.
That's the law.
ideal essence
Yes.
of
No,
social
no.
health.
I am saying they are assuming because it
Yes.
may be the law,
Yes.
but it will work when that is a reality.
Yes.
Yes.
Okay, but up to a point.
Yes.
Because remember, we are a country where people have even used examination results, which are not theirs, to acquire jobs. We, the same country.
Yes.
We are the same country where, in the Ministry of Lands, we're told they have an impenetrable system. That, okay, I think you know I'm going with this.
Yes. I've understood.
Yes. So as we talk about this new system, we are saying there are people who are already figuring out. Okay, let's understand this system first.
Yeah, so that we can know where
Yes.
we
Okay.
are.
Now, having understood. Okay.
operating.
Now, how do we subvert this system? So when you say progressive, it now makes sense because you don't wait for it to happen.
Yes.
You are constantly thinking ahead of them. Okay.
Exactly.
And that's why
And
the
maybe-
Act says everything must be done digitally so that there's a footprint
And maybe I'm
from
assuming
A to Z.
they will apply, say, like a case mix model of payment or diagnostic related groupings. In that case, you need maybe to submit the claim to some other party or experts to look, not just another processor. No, somebody else to look at the claim and see this presentation, does it align to the diagnosis? Because such mechanisms allows the diagnosis and the treatment to be aligned so that it is set to a certain tariff. If I come to the hospital and I have malaria, we know the payment you receive is XYZ.
Yeah.
If malaria and typhoid present the same, have the same presentation and mode of treatment, they are grouped together and are coded one tariff,
Yeah.
which you are paid. So there is no thinking. You came to malaria, this was the diagnosis, this is the payment.
Yeah.
So they can be rechecked by other person to see, is this doctor presenting the same mode of payment, model of diagnosing. And it helps even doctors try to be efficient because you will not be paid if I came in, if this was the diagnosis, and you started by taking me round, you are not hit on. The other aspects will not be paid for because they don't constitute to the line of treatment towards this diagnosis. So progressive payment mechanisms really help to improve doctors' efficiency and to try and cut down on
And
fraud
quality as well.
yes,
So I'm not
exactly.
coming to a hospital and you know very well I have malaria, but enda kwanza tupime typhoid.
And ufanye MRI.
Ulikunywa nini fanya MRI. So unasikia kichwa inauma sana. Pande ya mbele.
So I'm really hoping that we will move towards new payment mechanisms
So meaning
and even help the
there
other
are
private
ways-
health insurers.
there are ways that can be done, all these things in terms of setting up. But as City has said, the assumption and the prayer is that everyone will be a member and everyone will have a cover. So that you don't need, two of the benefits are already taxpayer. So it's only one benefit in the middle that you have to contribute to. But for you to benefit even the primary health care, so this becomes a requirement that you must be a member of the social for you to get the accident and emergency and critical illness and the primary
And the
health
primary.
care. Yes,
Now, to the both of you.
yes,
In this country, since 2003 January,
yes.
we've had free primary education. Do people cough money for their children to go to primary school? Public primary school in this country?
Yes.
Aye. For a couple of years, we've had free day secondary education. Do people cough money to do this? Yes.
Yes.
Now we are saying we are going to have free primary healthcare.
Yes. People will cough money to access. One way is they will have to go to that place.
Will
Transport.
they be gatekeeping fees?
It starts with, will the government follow through with this one? This same government that has not been able to follow through diligently with offering free education, will it follow through with offering free primary health care? And what happens when it doesn't?
All indications are the way I see. I told you it was June 27th, 2022. That's where these things started. Up to now, where we are, the journey seems to be moving progressively. And that's why I was telling you, even UHC is not an end destination, it's a journey. So it should be something that's continuously that we should push for. And one of the things why I see it will have to is the law, the current law that has been enacted, repeals NHIF after 1 year. So meaning it will not exist. So the Social Health Authority must come in its place after 1 year. And it must have those three funds.
It must.
It
Jeff.
must, as per the law.
Jeff, when Uhuru and Ruto came into office, they promised us free maternity. So, no, they were supposed to put money into NHIF so that NHIF can pay. Were you receiving that money on time?
Yes, we were, and we did run a program called Linda Mama.
Yes.
And it was very progressive. We changed women in especially rural areas to deliver in a facility with dignity. And that did happen. And I want to believe the program maybe is still on.
The program is there.
Yes.
Is the money coming
the
on
money
time?
came, yes. The money
Does
came
it
on
still
time.
come on time?
Oh,
I'm
well, for
asking
now, I
that
don't know.
because
But
we spoke to the chair of NHIF a couple of months ago when there were issues with people going to facilities and they don't have money. I mean, the facilities say, look,
Unless you have money, you can't reach you.
NHIF
Yeah.
has a bill. And the issue was, Ministry of Health had not put in money to, or the Treasury had not put money that they were supposed to put to NHIF. So NHIF was basically having a cash crunch because government has not done what the government should have done. What happens if government does not
Do what it's supposed to
do
do.
what government
during
should
my
do?
tenure, we never had any cash crunch. So,
So
but I wanted to say something about the laws.
Yeah.
About the laws, that these laws set a very good foundation. They set a very good foundation to form the base on us to move towards UHC. Because remember, we have launched UHC, I don't know, about 3 more other times.
Yeah.
But without the foundation and the structures, you find you will try to launch it, but it will collapse and come down. But I think now we have the laws and the foundation to be able to move on. And I think that's a good step.
Different laws, same people,
No.
same country.
Even people will be different.
What we need to keep in mind is NHIF, with all its problems, has really solved a lot of problems
Indeed, it has.
for
It
many
has.
Kenyans.
It has.
And that's why, for me, I only see a better future, not a worse future, because of the way this has been structured, the way this has been designed. So all we need is, as Kenyans, we need to move away from our individual WhatsApps, where we are contributing something for a relative, a friend, and move into that social health, which becomes our bigger WhatsApp, in my opinion. Because if we don't contribute together, then we will not be able to deliver this kind of services that is very ambitious.
So we
And
should all just say, like, let's contribute to
definitely.
this social health.
Yes,
Sawa.
let's contribute so that we also we are not pushed into poverty by trying to pay out of pocket.
Daktari, thank you for joining us. You guys will be back here. We'll be looking at how NHIF is progressing. Dr. Abdi Mohamed, Chairman of the Kenya Association of Private Hospitals, and Geoffrey Mwangi, former CEO of NHIF and health financing expert. Thank you for tuning in to Kenya's biggest conversation this week. See you on Monday. Have a lovely one. It's 10 a.m.
This is The Situation Room the only way to start your day.